sharing experiences, really important, learning from each other, hearing from our expert speakers.
I want everyone to really take control of their health, because it's your body and your life, and if you're not in control of it, no one else will be.
Turns out that almost all pacemakers are completely fine to go through an MRI scanner.
Both septal ablation and surgical treatment show good results. It's safe, comparable.
HRT for many women is a lifesaver.
However, and it was a real shock, they told me I did need a transplant.
It's funny being a carer. You know, sometimes people don't take their medicines properly and you get cross at them. Why are you not taking your medicines?
I would say the next big stage in the development of this story was our understanding that this is, in many people, a genetic condition. So it's a heritable and transmissible disease.
So some of the pros of genetic testing are that we can find a causative gene change in some people.
First of all, thank you to Cardiomyopathy UK for inviting me to give this talk. Can you all hear me? You can. Great, great. I've seen a couple of my patients already, so I feel a lot more relaxed. You know, I'm not a surgeon. I'm a heart failure cardiologist. I look after patients who have got heart failure. I also implant cardiac devices, which I will be talking about in my patients. I'll be talking about devices that we use in patients who have cardiomyopathy. Some of you may have some of these devices implanted already. And that's another one of my patients. And a little bit about surgery. Now, if you have any questions, just write them down. I'll do my best. I haven't got too many slides, so I do not expect to use the entire time. I'll be very happy to just have a conversation with you, so please feel as relaxed as you possibly can. So I'm going to look at, and I know you've been through gone to other sessions, but I'm going to talk about what is normal, or apparently normal. I'm going to talk about heart failure. I'm going to talk about devices in cardiomyopathy. I'm going to talk about when surgery may be needed. And then hopefully we'll be able to go through some questions. This is a very interesting quote that I quite like, and which most of my practice is based around. I think it's very important that you kind of get to know your patient, get to know who they are. And whenever I have, the juniors on the ward talking about a heart failure patient, I get a bit offended. It's the patient who has got heart failure. And those sorts of terminologies, I think, are very important, not just for the patient, but for the interaction that we have with them. William Osler was a cardiologist who basically, he's the father of modern bedside medicine. So doctors or medical students and registrars were in the labs and in clinics, but he brought people to the bedside, because that's where you learn properly about your patients. Now, when we talk about normal, with respect to the heart, we often talk about the size of the heart, we talk about the muscle thickness, we talk about the heart function, and the very commonly used measure of a patient's heart function is this thing called the ejection fraction, the percentage of blood that is pumped out with each beat. So if a heart filled up to 100 mils, every time it squeezes, it should squeeze out at least 50 mils. Then fill back out again. Might squeeze 60 mils out, meaning I've got 40 left, then fill back out. So a healthy heart should generally pump out or eject 50% of its contents with each beat. And we may also look at the valves. But regardless of what everything else at the top, so the size, the muscle thickness, so, heart function, is, the symptoms that a patient may have will usually persuade you as a clinician, or should persuade you as the clinician, to investigate further or change the course of the patient's treatment. That's the most important thing. I often say to my patients that I can't feel what you feel. If a patient has got pain, but I can investigate it, I can look for it, look for what may be causing it. And I feel for them that they have those symptoms, but I can't feel it. Nobody can feel what you're feeling inside. So I'm going to show you a whole series of images, okay? And I'm sure all of you are thinking, but we're talking about devices today. I promise you we are. This is an echocardiogram, an ultrasound scan of a patient's heart that is pumping normally. On the right is an MRI scan. It's, again, a heart that is pumping normally and looks structurally normal. It's pumping out more than 50% of its contents with each beat. It's got good systolic contraction. This is a heart that isn't pumping normally. So the heart on the right is somebody whose heart is maybe slightly enlarged. Dilated means enlarged, and isn't pumping as effectively as it should. This might be more apparent in this MRI scan, and this is just a rough estimate. That chamber that is being measured with the red line is the left ventricle, and hopefully you can appreciate the difference in size between what is normal and what is enlarged and not working as effectively. Then, of course, we talk about hypertrophic cardiomyopathy, so increased muscle thickness. And again, you can see on this particular image 2 different scans with different thickening of the muscles. Hopefully, it's apparent on the scan as well. So even though the heart is squeezing okay in the patient with hypertrophic cardiomyopathy, sometimes the muscle thickness is obviously abnormal. You don't need to be a doctor or a cardiologist to see that that is the case. On an MRI, it's probably even more striking, where you see that on this particular scan, you've got the muscle, and that's the septum, or the band of muscle that divides the 2 chambers, the left and right ventricles, very thick, and you can see that it's, very different to what is normal. So without even doing anything fancy, standard imaging can tell that there's something different between what is normal and abnormal. We have this thing where, sometimes a patient, clinicians, we communicate with ourselves. Clinicians are the worst at communicating with themselves. So I'll just tell you that now. You have to track things out of people. And I always say sometimes, when they call you about an ECG, oh, hi, Dr. Savage, I've got this patient, and they've got this ECG, and I'm not quite sure what it is. And I say, okay, can you tell me? But they often, and I honestly don't know who's responsible for some of the names or the nomenclature that we have in medicine. I think it was deliberately designed to confuse patients. I honestly do think. I think if I was in charge, I may have named things a little bit more simply. So I say, okay, forget whether you think it's a ventricular tachycardia or an atrial flutter or this or that. Just, is it fast or slow? Let's start with that, okay? Is it fast or slow? Because I need to know what I'm doing at 2 a.m. in the morning. So heart failure with a reduced ejection fraction. Hopefully you remember we talked about what the ejection fraction is. Fills up, squeezes out 50% of its contents or more. And so you will understand when we say somebody may have, heart failure is a rather unfortunate term, but it's a term that we can't really get rid of because it's important that we don't trivialize it. Otherwise, people don't get the care that they need. We can say a little bit of heart failure. The last person who said that, I won't tell you where I buried the body. Because it isn't a little bit. It is important and it's treatable. It is treatable, so you should identify it. So a patient has got heart failure. Their heart isn't working as effectively as it should, and they've got a reduced ejection fraction. If you saw somebody whose heart wasn't pumping as well as you can see on the right of your screen in that ultrasound scan or echocardiogram, the first thing to try to identify, because it's relevant for devices, is why, okay? Why is my heart not squeezing properly as well as it should be? Like in the scan, it's 10%. So you hear, or you may have heard, ischemic or non-ischemic. The heart pumps. For the heart to do its job as a pump, it requires blood supply. Blood supply in the majority of us in this room through arteries. Arteries are pipes. Pipes can get narrow or get blocked. Most people have 3 arteries supplying the heart muscle. I'm showing you 2 of them. An artery can get narrow, pinched. If I have an artery that should be supplying blood to my heart that gets narrowed and gets blocked, blood doesn't go to the heart muscle, we say the person's had a heart attack. okay? So they have coronary artery disease that has caused the arteries to block and the heart function has been damaged, or the heart muscle has been damaged. You say they've had a heart attack. So a heart attack can cause heart failure. Patient who has poor heart may have their heart failure due to coronary artery disease, and we say they've got ischemic heart failure. But majority of patients who have a cardiomyopathy will have completely smooth arteries like the arteries on the right of the screen. There's no blockage. And I'll show you that in a still image because it's easy to see. As you can see in this particular patient, it starts off as a fatty, narrows down, pinches out there, and all the way down. This patient ended up having a bypass operation. So what do they do with a bypass? They take a vein from your leg or from behind the breastbone, and they connect it to the top here and bypass the blockage. It's a new pipe. That's why it's called a bypass operation, which is interesting because I saw somebody the other day who had a bypass operation 15 years ago. And then while in the consultation, I said, well, so you know your bypass operation, you had a narrowing there and they connected something from here and they bypassed the narrowing. And the patient said, oh, is that what a bypass is? You had it for 15 years, so somebody hasn't told you what they did to you then. But we're moving away from this paternalistic relationship with our patients so that we can actually partner with them so that they can get the care that they need in the best possible way. So we say ischemic versus non-ischemic, okay? The primary goal in managing anybody whose heart is weak, that is, they've got heart failure, is to get them on medical therapy, so tablet treatment. We call this the 4 pillars of heart failure therapy. And some of these tablets you would have heard of or you may be taking, an ACE inhibitor, drugs like Ramipril, a beta blocker like carvedilol or bisoprolol, eplerenone, spironolactone, or indeed dapagliflozin or empagliflozin. So these are the 4 pillars. We know that patients who take these tablets or who can tolerate these tablets do better than those who are not able to take those tablets. Well, if you're not able to take it, there might be other replacements for you. So from the moment you make that diagnosis of heart failure, you should give patients tablet treatment for a period of time. Usually no more than 12 weeks so that you can make a decision. You should then reassess the heart function. We're measuring the ejection fraction. Remember, we knew the ejection fraction was weak. We give them tablets for a period of time. We reassess the ejection fraction, and then we look at it. If the patient's ejection fraction remains 35% or less in the context of heart failure, then we have to say, does this patient need a device? And I'll explain to you why at 35% that is needed, or that conversation has to be had. So it really should be a straightforward journey for our patients who have heart failure. So devices. Well, I'm going to talk about implantable cardioverter defibrillators. I'm also going to talk about cardiac resynchronization therapy, either with a pacemaker, CRT-P, or with a defibrillator. I'll clarify that in more detail. What does an ICD do, an implantable cardioverter defibrillator? It's a device that's implanted into the heart for one purpose, and one purpose alone. You have determined that this patient has a risk that without warning, their heart could go into a dangerous heart rhythm abnormality that could cause a cardiac arrest or death if they were not treated on time. And so that is what an ICD does. An ICD is implanted into the patient's heart to treat that rhythm abnormality if it ever happened. It's like car insurance. We all have to have car insurance, but you don't want to have used it, okay? Because usually, if you use your car insurance, it means something has happened. So oftentimes when I implant an ICD in a patient, I say, I hope you never get to use this, because I guess if you did, it's a good thing, but I prefer if you didn't, okay? I like to know that you have a risk and we've protected you, but I hope that risk never comes to the surface, okay? In terms of heart failure with a reduced ejection fraction, so a low heart, it doesn't change the person's heart failure, And this is important because I'll talk about cardiac resynchronization. It's there as a shock box, okay? So if you see a patient who has the rhythm abnormality at the top, those squiggly lines are not great, it will detect it, give the patient the treatment, usually in the form of a shock, and restore normal rhythm. That's what it does. So that's what an ICD does. An ICD can be implanted through the veins, and this is the commonest way an ICD is implanted. We make an incision or a cut just under the left collarbone. We look for veins in that region. Sometimes we put it in the right collar, on the right side, but most times it's on the left. And, sorry if you're left-handed in this room, but for those who, I was taught to put it on the left, apologies. Because it's the non-dominant arm for most people. So I do ask, are you left or right-handed? And they say, oh, I'm left-handed. Like, oh, let's go to the other side. Okay. And then the leads are put in through the veins into the heart. It's in direct contact with the heart muscle. We deploy a tool or a screw that fixes the lead into the heart muscle. It can treat the patient if they went into that dangerous heart abnormality by delivering a shock. It can also treat the patient by delivering what is called ATP, anti-tachycardia pacing. And the way I explain this is, if you were in a race, maybe Christy at the back, maybe he's an athlete, and he was on a race with Usain Bolt. Christy is our ICD. Usain Bolt is going all the way, and that is the bad rhythm, going very quickly. But Christy goes faster than Usain Bolt, and then suddenly stops, and then puts the patient back into a normal rhythm. The patient is completely unaware that happened. Don't even know that it's happened, What you get is, hi, we just received an alert from your device telling us that you've had some treatment from it. Really? I was skydiving. Yeah. And then, oh, okay. But you've actually been treated from that device. So it's a key point to make about ATP, because obviously shocks can be unpleasant for people, and not just the person, but for the caregivers as well, or for those who are around. I know a few people who have had that. And so if you can avoid giving a shock, it's a good thing, basically. An ICD lead can act as a pacemaker because it's in direct contact with the heart muscle, so it can also do that function, and it works effectively. An ICD can also be implanted subcutaneously, so entirely subcutaneously. And what we do is, either under a general anesthetic or nowadays conscious sedation with a type of block, just at the patient's side, we make an incision. Between two muscles in that area, we're able to put the can or the generator or the box, and we then tunnel the lead across the chest wall or the rib cage for the coil to lie next to the breastbone. Nothing goes into the veins, and therefore nothing is in contact with the heart muscle at all. Everything is on the outside. I think it's a great addition to the therapies that we can offer patients who, by no fault of their own, may develop a cardiomyopathic process, It can only treat by delivering a shock only. It cannot provide ATP. Remember the ATP I described? And so that's what it is. It's a shock box and a shock box only. Cannot deliver ATP. It also cannot act as a pacemaker because it's not in direct contact with the heart. And so if I was implanting it in a patient who I thought in the medium or short term was likely to require a pacemaker. Now, I'll explain the concept of a pacemaker for those who don't know, because I know there's a lot of educated people in terms of their conditions in this room. But I am on call for cardiac devices in Essex. There's 1.5 million people. I may get called in at, stupid o'clock because somebody has had an emergency. What you will hear is 70-year-old Bill from Wickford has collapsed, okay? And he's been brought into hospital. I may get there and find that his heart is doing this, and then stopping 1 second, 2 seconds, 3 seconds, and then stopping. So the electricity in his heart has kind of failed. That's just wear and tear, maybe he's, or from other conditions he has. So Bill needs a pacemaker, okay? That's all that a pacemaker does. So I go in, I put in a pacemaker, and what Bill would have been having, he's having periods where he's feeling really dizzy, like I'm going to pass out. You call the ambulance, but by the time the ambulance gets there, as is always the case, oh, the heart is nice and normal, okay? I've been getting these dizzy spells. Okay, don't worry. Why don't you wear a monitor for 24 hours so we can catch it, okay? We can catch those periods where your heart is just pausing and doing nothing. That's what a pacemaker does. You put the pacemaker in, and every time the heart just goes too slow, the pacemaker kicks in, and Bill doesn't even know that has happened. The heart stays completely normal. So if I was going to implant a defibrillator in a patient that I had concerns that already the electrical wiring in their heart may mean that they may need a pacemaker soon, okay, then an SICD might not be such a great idea. I might want to give them a transvenous one because I know that that will both be a defibrillator and give them pacing if they need. But many people don't need a pacemaker for the treatment with an ICD. And I put in bracket yet, because technology is changing a lot. And subcutaneous ICDs work quite effectively. Of course, because you're nowhere near the heart, there's less, issues with the lead that can sometimes be a problem when you have a transvenous system. So who may need an ICD? Well, I've explained to you that if you had somebody who had heart failure with a reduced ejection fraction, you've given them a period of time where you've given them tablets to see if their ejection fraction gets up. The medicines are still doing their job. However, at the appointed time of reassessing their heart function was less than 35%. They carry with them a risk that without warning, their heart could go into a dangerous heart rhythm abnormality. And so you should offer them an ICD. So in this patient, their heart function is abnormal and they have the risk of an abnormal heart rhythm. What about if it was more than 35%? Because, the guidelines are strict. They say less than 35%, you should definitely do that. But there are patients who have heart failure. The ejection fraction is 49%, but more than 35%. Or maybe they've been having lots of rhythm abnormalities that are just short bursts, They don't last very long. Or maybe on a scan, we have seen that they have a lot of scar tissue within the heart muscle. Or maybe we've identified a gene within the patient that means that they are high risk of dangerous heart rhythm abnormalities. We may consider an ICD in a patient like that. So a lot of conversation has to happen about that sort of situation because it's kind of outside the guidelines, but it requires people who are all thinking together in conjunction with the patient's wishes. Now, a patient might have completely normal heart function, like in a hypertrophic cardiomyopathy. You might see that. But the structure is abnormal. Remember, the hypertrophic cardiomyopathies are the patients who, in hypertrophic cardiomyopathy, the patients have got thickened muscle. And so, it's kind of not completely normal structure, and so they may carry a risk. And I'll show you what risk scores are used for those patients. You could have an apparently normal heart. Normal function, so ejection fraction more than 50%, normal structure, but they've had a cardiac arrest. You've checked everything, can't explain why. Or maybe they've got a gene. Or maybe you're suspicious that they may have one of these channelopathies. Channelopathies are a problem with how the body or how the cells utilize salts like sodium and potassium, how they're moving across the cells. So even though their heart function is normal, because sometimes you see a patient, completely normal function, but they've got an ICD. It might be for one of these reasons. So you can see, I guess I put it this way to explain that there's a whole range of patients. And the most important thing in making a decision about putting devices in patients is that everybody is talking together and that the patient is fully aware of what the decision is to be made about their care. So this is an example of a patient who is taking, what would be considered champagne medical therapy, then all the tablets that we want for their poor heart function, but the ejection fraction hasn't improved. The tablets are doing a job because without the tablets, the risk of, poorer outcomes would be there. So you will consider an ICD in these patients because they could develop, start off as a normal rhythm and then end up with an abnormal rhythm. So let's just put the ICD in. They may never need it. In patients who the cause of their heart failure is non-ischemic. Who remembers what ischemic, non-ischemic means? Yeah? If it's non-ischemic, like most cardiomyopathies, the risk of, having a dangerous heart rhythm abnormality that may cause a cardiac arrest is, probably 1% or less. We're getting closer and closer. Of course, for some patients who have certain genes, that risk is slightly higher. But for broadly speaking, that means 1 or 2 people out of 100 every year will be at risk of that event. Another way to look at it is if I implanted 100 ICDs every year, 1 person or 2 people will use it that year. 98 people won't, And then the next year, it kind of resets again. So every year, you're kind of in the 2 or, 99 who might need the ICD. Brugada syndrome, that's another, this is now, normal heart, but have got an abnormal rhythm risk. So this is what like a normal ECG might look like. This is what a patient who has Brugada syndrome, the ECG has got this characteristic coving on the complexes, and they carry that risk of developing that heart rhythm abnormality. They may be offered an ICD. You may have also heard about long QT syndrome. I know some sessions have talked about some of these channelopathies. The QT interval is an interval on the ECG. We measure certain intervals, and the QT interval has a certain duration. And in patients who have a long QT interval, that duration is quite long. Hence the name long QT, I guess. That's probably the only normally named thing in cardiology. That and that. And so that predisposes them to the risk of having a dangerous heart rhythm abnormality. We talked about hypertrophic cardiomyopathy, and Professor Perry Elliott has been in and around the conference, and he's helped develop this risk score. We've been using it for years. And it's a score, so if you saw somebody who had, remember, if your ejection fraction was less than 35%, that's almost easy, as a decision. You could think, well, why should I not offer this patient an ICD? Okay? That's the only question you have to ask. If a patient's ejection fraction was normal, but they've got hypertrophic cardiomyopathy, you have to ask, why do they need an ICD? And so we've always known that they carry a risk, okay, but when do we offer it to them? So we look at a whole host of parameters. This slide hasn't come out as well as it should, so sorry if you can't see. We'll look at the family history, the presence of non-sustained or occasional heart rhythm abnormalities that could potentially cause, that could become more sustained. Whether they blacked out unexpectedly and nobody can explain why. And then we put all of that into this very well-validated risk calculator, and it gives us a recommendation based on very good data. In this case, this person has got a low risk, so it says not really indicated. And in this person, they've got a very high risk, so we say it is indicated. I do have to mention this because I think it would be poor of me if I didn't. But there are many clinicians and many of my colleagues don't like to talk about this with their patients, but I do. There are times when a patient may not need an ICD, when actually the treatment goals for that patient are beyond what an ICD will be able to offer them. In those patients who develop other medical conditions, remember I told you about the chance of the annual benefit of using an ICD somewhere around 1 to 2%. But if a patient developed cancer, or they developed other conditions that meant that their life expectancy was always going to be affected by that new problem, then an ICD is probably not a good thing for them to have active. because then that would be a cruel way to manage a patient. And all we do, I swore an oath 21 years ago, believe it or not, when I finished medical school, I said, I first do no harm, okay? And doing no harm also involves making sure you don't give people therapies that are likely to cause them harm. But the biggest challenge often is because none of us tell the patient at the start that there is, and we use such ridiculously emotive language like turn off. I mean, if anybody came to me and said, I want to turn something off, I'd be like, no way, you're not turning anything off, okay? We might deactivate an ICD. The same way a patient may say, I do not wish to be resuscitated. 50% of my patients, I say, John, have you thought about what happens if your heart stopped naturally or your breathing stopped naturally? And they say, well, yes, I mean, we've talked about it, I've got an advanced plan, I've got power of attorney. They say, the other 50% are shocked, oh, Dr. Savage, I thought you were trying to make me live longer. Well, I am, but I also have to look after that part of your life because that is good care. So that's one thing to say. So ICDs may treat dangerous heart rhythm abnormalities like this. Does anybody know what the rhythm abnormality on the top is? There are no Americans in the room, right? Okay. Right. Cardiac resynchronization therapy. Cardiac resynchronization therapy is a mouthful, but it's another way of saying biventricular pacing. So imagine a patient's heart is weak, right? So we say this is a heart that's, very strong, pumping well, and then this is a heart that is kind of weak. Some people have their heart that is weak, but pumps together. Some people have their heart which is weak, but does this. So it's kind of out of sync, okay? So the left, usually it's the right, goes before the left. They should contract at the same time, whether they're weak or they are strong, okay? And so if you see a patient who has got evidence of dysynchrony, maybe we could help them, In fact, somebody said to me the other day, oh, Dr. Savage, you've only offered me an ICD. Why can't I get one of these cardiac resynchronization things? And I said, well, it's because your ECG is too good, In many ways, that's almost the way it is, because there's no evidence of that dysynchrony. Your heart is good. This is actually not too bad. The small changes, but that can make a big difference to a patient's life and those who respond. It's also known as biventricular pacing. And I've talked about putting a lead into the heart. This is a lead in the top chamber of the right side of the heart. This is a lead in the bottom chamber of the right side of the heart, so right ventricle. But then through a vein that goes to the back of the left side of the heart, we can force that lead and that lead to make the heart pump stronger. So biventricular pacing. So of course, this can increase and this can potentially improve a patient's function. I was talking about ECG. So that's a normal ECG, and this complex in the middle here is the QRS complex, and this is basically what we use to make a decision about whether there's evidence of dysynchrony, and this QRS complex should not be more than 130 milliseconds, and hopefully you can see that there's a bit of a difference between those two. One is wider than the other. It's wide because it's taking a long, so 120 milliseconds. In fact, in patients, 80 milliseconds, that's super quick, right? So top chamber, bottom chamber, it should go very quickly, right? Or you have, so it's a lull, it's a drag. And that usually means one chamber is pumping earlier than the other. Make sense? So who may need an ICD, a CRT? Well, if the ejection fraction is low, if we have evidence of dysynchrony, but I hope you noted that I said tablets first. I'm a conservative device implanter. I always say that you should give treatment, medical treatment first before you start putting metal in patients. Of course, you put it when you have to, but we should always give tablets first. So CRT, low heart function, and maybe evidence of dysynchrony, then we'll consider them for that. You can put a defibrillator as the right ventricular lead or leave it as a pacemaker. That's where you hear CRT-D or CRT-P, right? So you're pairing it with a defibrillator or you're leaving it as a pacemaker. And this is what the implant looks like. Most people understand that you can put a lead in the bottom chamber. This is a catheter that is going into the veins that supply the back of the heart. Okay, so I put a catheter in there, and then, using this is all magnified, by the way, just so you know. This particular vein isn't as huge as it looks like on the screen. I know that because the catheters we're using are small, and then when you look on the screen, this looks very big, but it isn't, okay? And so we were able to see that. So the difference between CRT-P, CRT-D, I don't know if you were in a pub quiz and you wanted to win something. Remember I said right atrial lead, right ventricular lead, left ventricular lead. Can anybody tell the difference between the right ventricular leads? One word answer only. Sorry? Size, that's absolutely correct. This has got a coil compared to that doesn't have a coil. So this tells us that this is a defibrillator. See, medicine isn't complicated. They just deliberately make it so, and I don't know why. See, that's a coil compared to that. So cardiac resynchronization therapy with a defibrillator and cardiac resynchronization therapy with a pacemaker. That's the summary of devices. And I've got 5 minutes to go through surgery, which is perfect for me because I'm not a surgeon, okay? And I saw this paired with what I was doing, and I thought, gosh, I don't actually do surgery. Most people who require surgery for hypertrophic cardiomyopathy, for cardiomyopathies, are those who have an obstructive variety of hypertrophic cardiomyopathy. There's an obstruction to blood flow out of the heart. And usually is in patients where tablets have not been useful to help control their symptoms. And the two common techniques are septal ablation using alcohol, and I'll show you what that looks like, and septal reduction surgery. But it's important to actually understand why that is even needed. In this image, cardiac MRI, that is the left atrium receiving good blood, oxygenated blood from the lungs, and the blood should flow down into the left ventricle, which will in turn flow out through the aorta. The aorta is the big pipe carrying blood to the rest of the body. Hopefully you can see over here that this huge band of muscle is obstructing the flow of blood in that area. Does that make some sense? Yeah? And so it is that causes a patient to present with the typical classic symptoms of obstructive cardiomyopathy. With alcohol septal ablation, using, again, very fine catheters, high concentration of alcohol is injected into arteries that supply the heart muscle, almost like deliberately giving the heart a heart attack. It shrinks the muscle in size. Patients get their symptom relief pretty quickly. And I'll show you, I think I have something, yes, just over there. So you can just about see that muscle shrinks away and gets rid of. Septal myectomy isn't new treatment. This is the specimens from St. George's from 1958 and the original technique for treating this problem surgically from the Mayo Clinic in 1959. And again, that's what blood flow should look like in a heart that has normal wall thickness. And I hope you can see again that there's that obstruction to blood flow in a patient with hypertrophic cardiomyopathy. So what do? They simply go in and they take that bit of tissue out. Of course it's open heart surgery. Of course it's a longer recovery, but it does work. And all the data across both septal ablation and surgical treatment show good results. They're safe, they're comparable, different risks for each of them, but patients get the benefits is the most important thing. And finally, technology is changing and it's continuing to change. That's the first sort of pacemaker that was implanted. And this is, leadless pacemakers the size of a €1 coin. And so the technology continues to evolve. And thanks to the charities like this that support research, there's hope for us all. There's more that will be done and there's more research. But, you know, we're standing on the shoulders of people like this who have done the work that we have today. Rune Spears implanted the first pacemaker in Arne Larsen, and the first pacemaker lasted 30 minutes. So, and he had to put in new boxes. He had 30 pacemakers in his entire lifetime. But crucially, he outlived both the surgeon and the engineer. That's my team from Essex. Thank you very much for listening.
Thank you, Dr. Savage, from all of us. That was an excellent talk. Christy's going to come round. If you've got a question, please put your hand up and Christy will pick them from, and we'll do our very best to ask them all. I'll come and get this one from over here, and then I can start asking. Okay, so first question. Is it possible to have dilated cardiomyopathy and hypertrophic cardiomyopathy, or is it only one or the other?
Well, that's a great question. I think, you know, you can have different varieties of a cardiomyopathy. One usually predominates, and so that there is no confusion, we will often try to say, it's a bit like a patient who has a non-ischemic substrate for their heart failure. Substrate means cause, non-ischemic cause, but they've got some coronary artery disease. What we refer to the coronary artery disease is bystander, because there's enough that tells us that the coronary artery disease we've seen is not what's causing their heart failure. So a patient may have hypertrophic cardiomyopathy, features, and look dilated. We will do our best to nail it down to one cardiomyopathic process, because clearly it influences the treatment you get.
Thank you. Sorry. What is the approach if a lead is interfering with the phrenic nerve, causing a diaphragmatic contraction? If change in polarity, does it work? No, if change in polarity hasn't worked, sorry.
That's a difficult one as well. So what that means for those who don't understand is sometimes when you put a lead into the patient's ventricle, remember I said we screw it in, usually we aim for the bottom part of the ventricle, so the apex of the ventricle. I'm normally teaching and drawing on charts. I don't have something to draw, but anyway. And because the bottom of the right ventricle is close to the diaphragm, when the patient has pulses going through the lead, they can get that twitching of the diaphragm, okay? So there are many things you can do. You can try to change how the current passes through the lead. You can try to change where you pace from, either from the can or the lead or the pulse. But sometimes you can reduce the amount of current that you go down through the lead. You can reduce the duration of how you pass the current in. Because you see, to pace if this was a little bit of heart tissue, like if I was in the lab and I had the lead in, I can pass 1.5 volts through to cause it to contract, 1.5 volts through for 0.4 milliseconds, or 1.5 volts at 1 millisecond. So I can increase the duration, I can shorten the duration. So there are many manipulations that we can do, but sometimes it might just be the patient's body habitus. It is impossible for you to pace from that lead without them getting phrenic nerve stimulation. We may have to put in a lead that is pointing in a different direction, like on the septum. Like I suspect that if I have ever had a pacemaker, I'm so slim that, you know, I'm definitely going to be walking around like that. You know?
There's two questions about sizes of ICDs, so I'm going to combine them together. So it said, I've seen some small ICDs on the market, and certainly the other question reflects around size. Is it more difficult in smaller people, and can I choose the size of my device? That's two questions in one, really.
Okay, so one of my last implants was a lady who was 4 foot tall, okay? When I saw her in clinic, I thought, where are we going to put it, you know? And I was like, Jane, what are we going to, Jane isn't her real name, don't worry. I was like, what are we going to do, you know? I mean, you're not as tall as my 7-year-old, you know? So we have a good laugh, and yes, small people, you know, for lack of a better word, you know, you might struggle because of their size, But oftentimes it's more about where you're going to put the generator. So it's thinner people that you might struggle with, because actually we're putting things under the skin, and because we're putting things in a subcutaneous device, you're putting it under the skin, you need a little bit of padding, to be able to get over it so that you reduce the risk of erosion. People who are too overweight obviously carry their own challenges as well. The devices that we implant through the veins are smaller than the devices that we implant subcutaneously. But remember, I showed you a slide at the end showing 1958 to 2014. I can guarantee you that that is going to change over the course of the next few years. So transvenous devices are smaller than subcutaneous devices currently. Small people, maybe it isn't so much as this. What's the difference with a shorter person? Well, the length of the lead is the same. So it just means I have to coil more up here than I will have. If I had a 6'5" patient, I'll have more of the lead in the patient, less of it in the pocket. If I had a 4-foot patient, I'll probably have more lead here. What do I do with that? Okay, roll it all up, tuck it under, zip it all together.
So there's a question around if someone's had lots of wires and changes of devices, is there at any point where the wires can't be fed into the heart, and what would be the option then?
So we put leads through veins, right? So you put the lead, and the lead travels, say, from here all the way into the heart. So it's a vein. The pipe, before people like me turn up there and start putting things inside them, were nice and open. In some patients, when you put a lead in, it may clot, okay? But, as God has made the body, what happens next is that it's a bit like damming a river. It finds a way around. So if this was blocked, and in fact we do tie up some veins, veins bypass the blockage. Sometimes the blocked area might be very long, and that may affect subsequent passing of any leads in that area. So sometimes I may, in cases where you want to upgrade a device from an ICD, 1 lead, to CRT, 3 leads, I want to keep everything on that side. So what I do is I take a picture of the veins and I see that, there's some narrowings there. We try, but we can't. We may have to put an entirely new device on the other side. Everybody is different. Sometimes you have a patient who has had 3-4 leads into their heart, and the veins are still smiling at you the next time you get there, and there's nothing that can predict that. The only thing you can do is check at the time. We try not to leave redundant leads in patients if we can, okay, because of the risk of infection. But sometimes you have to, it's always a risk and benefit ratio. An extraction procedure carries with it quite significant risk. And if I was going to extract a 20-year-old lead, I'll have to think about, whether my risk is here and my benefit is here. That's what I like. If risk and benefit are talking to each other, I need to ask myself why I'm doing what I'm doing.
Thank you. And the other question is around surgery. So when might someone in their 20s with a hypertrophic cardiomyopathy explore septal ablation?
So my last slide, which I rushed through actually, was that whatever you do, you should speak to your cardiologist and your surgeon, and whoever is looking after you, you should ask those questions. I think that for surgical treatment, you have to go based on the patient's symptoms. There are newer medicines in the market. At the Essex Cardioverter, at my center, we're one of, I think, 4 in the UK trialing, new licensed drugs. And, I can tell you that the way we treat patients, and I'm sure you all know, as part of the charity, the way what we have to treat patients now, compared to 21 years ago when I came out in my nappies, right, is very, very different. For medical school, that is, by the way. Okay. And so we've got much better therapies. I would say speak to your clinician. If your symptoms are not controlled on tablets, tablets should always be first, I think, or exercise programs, then it's never too early to have a good quality of life. Ultimately, that's the most important thing. I think the only reason why you're asking questions is because you want to have a good quality of life. So if you're young and you can't do what a 21-year-old is able to do, and you're concerned about that, then you shouldn't suffer. You should never suffer if you can avoid it.
Thank you. We need to draw it to a close because obviously we've got a break now and then the next session starting shortly. So can we just say a big thank you again? Excellent talk.